Right. Hello, everyone. As you're joining, we'll just allow a few more people to join. Our numbers are picking up. Just as you join, just ensure you're on mute, and you can have your cameras on or off as you choose. And we'll get started in a few minutes. This is being recorded, just so you're aware. And we'll get started in a moment.
Do you want me to pop up them slides?
Yeah.
Yeah.
Yeah. Thanks, Audrey. Okay, so we'll get going very soon. Our numbers are picking up and up. Okay, I think we'll get started so that we can have a timely finish. So you're all very welcome to this evening's webinar, the title of which is Focus on Medication Safety. And for this evening, we have two speakers. And my intention with inviting two speakers this evening was to give some insights into some different aspects of some current projects and initiatives on medication safety. So with some primary care, with some secondary care focus. So our two speakers that will be speaking this evening are Eileen Relihan, who works in St. James's Hospital. And Eileen has joined us previously on webinars with the Irish Institute of Pharmacy, and her previous sessions have been so popular, and the feedback has indicated that individuals would like to hear more from Eileen. So that was our intention of inviting Eileen back. And similarly, Louisa has joined us on webinars previously as well. So the way we're going to run this evening is that Eileen will speak for about 25 minutes, and then we'll pause and take some questions on Eileen's slides, and then we'll move on to Louisa. So and similarly with Louisa, we'll speak for a little while and then take some questions. So do bear with us as we just transition from one speaker to another, and we will endeavour to answer all your questions that you have based on their presentations. So just in terms of the domestics for this evening, many of you I'm sure have joined us many times on webinars such as these before. For the purposes of the webinar, if you could mute your microphones, they should be automatically muted, but please ensure that they are so. You can have your cameras on or off, it's up to you. This is being recorded, and the recording will be posted to the IAOP website in due course. The chat box, which if you just hover on your screen should appear at the bottom, you can type in there to ask questions, and as I said, we will pause for questions at different points during the presentation this evening. And there will be an opportunity to provide feedback. We'll give you a link to a feedback survey at the end of the webinar as well, and then give you information about our next webinar that is planned. So that is the plan for this evening. I hope that's okay with everyone. So without further ado, then I'll stop talking. We'll move on to Dr. Eileen Relihan, who will just get the slides up and running here. Over to you, Eileen. Thank you.
Thank you so much, and thank you so much, Mary Claire and Audrey. It's a real pleasure to be here, an honour this evening. And I know I've spoken before, so people may be very familiar with this topic. For those who are not, just a very quick intro. The Medication Safety Minute is, I suppose, an initiative that we run from St. James's, and the idea is that we communicate medication safety messages, which are very short, bite-sized nuggets, really, of information relating to medication safety. The idea is that they can be read and understood within literally 60 seconds, and our target audience is doctors, but they are circulated to pharmacists, nursing staff as well. And with the perspective we're taking is what do you need to know from a medication safety point of view in relation to medication safety issues from, I suppose, a whole breadth of topics. So I suppose the angle I'm coming from this evening is to elaborate a little bit more on what is the inspiration for the medication minutes, literally where do they come from, what's it all about. So if you could move on to the next slide there, Audrey, thank you. Great. So I guess when I was thinking about this presentation, I was thinking, okay, the first thing we do or we have to do before we can issue any medication safety messages is gather intelligence. So I suppose I have this term medication safety intelligence for the hospital, and we gather information in a whole host of ways. And I suppose one of the points I often think about is that we wouldn't want to be relying entirely or anything like it on a reporting system, because as we know, you only get a fraction of incidents reported, and there's a lot of bias in the system. Very, very important source of information, but you really need to blend it with lots of other sources of information. So I have, for example, in there in my first circle, audit. I have the word conversation, and by that I mean literally those casual conversations you have with people standing in the coffee queue, you know, and you run into somebody by chance. That can be where you can get your really important information sometimes, because people probably are more relaxed and they'll mention things to you maybe that they wouldn't in as an official capacity. They may mention something they have a concern around or that they want to look into, etc. Obviously, you know, literature review in the sense keeping abreast of what's happening elsewhere in other jurisdictions and thinking, is that applicable to my location as well? And then things aside from reporting like claims and complaints, very valuable source of information, because very likely it'll be information that won't have been picked up by the reporting system. So it's additional knowledge that you can blend with the information you already have. And then surveys of staff, we would have done that, continue to do that with our staff in terms of what, for example, even asking them what are their top 5 medication safety concerns in the organisation. If it's anonymous, it's amazing what people will actually reveal to you. So that's gathering intelligence. So I suppose to put in context then, where does the medication safety minute fit in? And I suppose I would see it as embedding learning. So we have the intelligence, we need to then get the lessons from that, the learning points if you like, and then embed the learning. And we do that in a variety of ways. And really the med safety minute is just the cherry on top. So it's a nice cherry, but it's only the cherry. So I guess you have all of your other functions going on, like your policies, protocols, guidelines. Then what I have this rather scary term here, forcing functions, but by that really I'm talking about our electronic prescribing system, whereby we can guide people down the correct course of action through things like order sentences, you know, I suppose requiring them to specify a reason for bypassing a particular interaction alert, or allergy warning, that type of thing. So you can force the right action if you like. And then teaching, of course, which is incredibly important, but also very challenging because of the rapid turnover of the workforce, which is just par for the course in a teaching hospital. So that's where I see the medication safety minute fitting. It's the cherry on top. And what I want to do, I suppose, in the next few minutes is just show you a variety of ways whereby we get the inspiration, if you like, or the idea for the medication safety minutes, and how the medication minute then is kind of like the last step, if you like, in kind of the circle of learning. That's hopefully what I can get across this evening. So if we go to the next slide there, please, Audrey, thank you. Okay, so when I was thinking about this, I thought in a very simplistic way, I suppose, really, medication safety minutes tend to be either coming from a proactive standpoint or reactive. So proactive in the sense of we often use them to alert or advise about something, even when nothing has actually gone wrong yet, that we're aware of at least. So it's about preempting error, it's about minimizing risk, alerting people, and that can be as a result of a risk we've become aware that has become known in another jurisdiction, or it could be regarding new policies, procedures, guidelines that we want to alert people to in some way or other. And I'm going to give some examples of this now very shortly. So that's upstream, that's your ideal. So if you see this little guy going along here in the canoe, ideally, you know, you want to warn him that there's a crocodile downstream before he sort of happens upon it. So you want to preempt and prevent the danger, if you like, coming to pass. I suppose traditionally what you would have had is the more reactive type approach, where you're maybe more reliant on a reporting system to tell you something has actually gone wrong. The horse is bolted, if you like, the deed is done. And that's incredibly important too. So I think it's a blend of both. And really, this, if you think about kind of a schematic about where we get our thinking from, it's a blend of both the proactive and the reactive. So next slide, please. Okay, so I'm going to show you a few examples from both a proactive and reactive point of view, really, I suppose, and hopefully the examples will get across, you know, the concept of the way we go about our thinking. So from a proactive point of view, we often will use the medication safety event to highlight a new guideline to increase awareness. So a recent example was a new paracetamol poisoning treatment algorithm, or algorithms rather, we introduced into the hospital. So if we could go to the next slide, Audrey, please. This is an example of just one of those algorithms. We actually have a series of 5 of them, which depend on the time following ingestion of the toxic dose. So this is the one that's applicable to ingestion of the paracetamol toxic dose over a duration of less than 1 hour, presenting 8 to 24 hours post-ingestion. So increasingly, I suppose, I've observed, or I'm kind of aware of, that we're migrating a lot away from lengthy protocols. Well, we may have them in the background, but moving really more towards algorithms and flowcharts of this type. They're much more, I think, realistic from a user point of view. You know, if you're actually in a pickle and you're on call, you're going to want to pick out something that is quick and easy to follow. Of course, it's challenging to get information like this into a way that is, you know, that is brief but yet very clear. So we did a series of this and took a lot of work with pharmacology and therapeutics team, and also the ICU consultants and ED as well. But we got there in the end. So if we go to the next slide, please. Thank you. And then I suppose when we had all of that in place, we then embedded it in our electronic medicines guide. We then built a paracetamol poisoning plan on our electronic prescribing system. We updated our IV administration guidelines. And then finally, the last piece in the puzzle was the medication safety minute. So this is just a little bit of a play on the name of the paracetamol poisoning protocol, which is SNAP. So what's it called? Step, stop, snap, or snatch. So you've got the little guy hatching here, and of course, if we go to the next slide, then if we can move to the next slide, please. Great, thank you. And this is what the SNAP protocol is all about. And I'm sure many people are familiar with it, but just a quick word for those who are not. It's just a simplified version, I suppose, of the traditional 3-bag N-acetylcysteine regimen for paracetamol poisoning. It's a 2-bag regimen over a shorter period of time. It's associated with far fewer instances of nausea and vomiting, lower risk of anaphylactic reactions, and it is as effective as the evidence would suggest. So that was, I suppose, just an example of one example of where we got, I suppose, our thinking for the need for a medication. And this is really about alerting people, telling people there is a new protocol in town. This is what it's about. Be aware of it. It was all built into the system anyway, but just to try and, I suppose, reduce that shock value if people are seeing it for the first time, they've heard about it. So if you can move to the next slide then, and I'll just give you another sort of, I suppose, a map of how we come up with these ideas. This again was kind of proactive in the sense nothing had gone wrong per se, but we do audits every year, a number of audits every year. And one of them a number of years ago was in relation to an audit about the management of hypokalemia. And then in the course of doing that audit, if we can move to the next slide, actually, please. Thank you. In the course of doing that audit, I suppose we got into discussions with the diabetes team, the endocrinology consultants, and they said, you know, our instinct is a lot of these incidents of hypoglycemia are arising from the treatment of hyperkalemia. And so we audited that. And so one audit led to another. And then we recognized, you know, that it was very likely that the amount of insulin we were using as part of our hyperkalemia audit was excessive for patients with poor renal function, and they needed additional, and that all patients needed additional glucose also. So in light of that, then we revised we really, I suppose, not revised, but we generated a new algorithm for the treatment of hyperkalemia. And then we ultimately re-audited the impact of that. And what we found was a big improvement, I suppose, in the quality of treatment, but that there still was room for improvement in that we needed to increase the use of the hyperkalemia plan. And we did that. It's sometimes very, very simple things that will guide people when they're trying to find something on, again, it's electronic prescribing. So literally what you type in will affect what in your search box will affect what appears in front of you. So what we did was in the hyperkalemia plan nomenclature, in the actual title of it, we put in the, if you like, the ingredients, for the treatment of hyperkalemia, which meant if somebody typed in, dextrose, or they typed in insulin, then the hyperkalemia plan will pop up as a possible option for them to consider. And in that way, we drove people towards using the plan, and then we drove them towards the correct treatment for hyperkalemia. So if we go to the next slide, please, I can just show you what the hyperkalemia treatment algorithm looks like. Obviously, this is very, very small font here, but if you can see in the center box there about the actrapid dose for treatment of hyperkalemia, you can see 5 units for patients with renal impairment. That was a decrease from the 10 units for patients who have normal renal function. So it was that together with an additional glucose infusion, which is mentioned there in point B, additional IV infusion of glucose 10%. It was those two, I suppose, interventions which were new, but the entire algorithm, I suppose, was put together in a way it wasn't previously available as, and was simpler and easier to follow, we hoped. If we can move to the next slide then, please. And this is the medication minute that we built on top of that. And it was really getting across the idea that, and this is one we recently republished, people may have seen it on the Twitter feed, about literally hyperkalemia can start a chain reaction. And before you know it, you're gone from the frying pan into the fire. And particularly so if you're monitoring of your glucose and your potassium, or your glucose levels in this instance, are not at the level or the frequency that they should be, which unfortunately we had an issue with as well. So literally you could be going into the realm of hypokalemia or hypoglycemia without realizing it, and it can happen quite easily. So if we go to the next slide, then we can see the response or the answer to that, and obviously the answer was hypoglycemia. So hyperkalemia treatment, you can end up with hypoglycemia. You go from one serious condition to another very, very potentially serious condition. So that's what we want to avoid. So yes, again, hopefully this illustrates, I suppose, really the cycle of what the package, if you like, that we try to put together. So we go on to the next slide, please. Audrey, thank you very much. This is the third and last example of proactive type, I suppose, impetus for reducing medication safety minutes. This was a knowledge gap. This is just one of many examples, but the pain team, I suppose, proactively coming to me kind of saying, we know there is a problem with people not being aware of withdrawal syndrome with oral baclofen. We see it abruptly discontinued, adverse effects as a result. Can you help us in terms of making people more aware of this issue? So if we go to the next slide, please. This was very, I suppose, kind of a straightforward one. And it was really just an awareness knowledge issue, trying to drive home the fact that this can happen, not just with, intrathecal baclofen, which people might be aware of, but with oral as well. It's very easily prevented by slow discontinuation or slow tapering off. If you go to the next slide, please. Thank you. And really, we have our image here of our snail, trying to get across the idea that you just want to slow things down. Successfully reduce the dose over 1 to 2 weeks, can avoid an awful lot of potential adverse effects in that way. And it very easily treated if it does happen, basically reinstate your baclofen or increase the dose slightly. But it's just an awareness issue, really, with this one. If we could go to the next slide, please. Thank you. Yeah, so this stage things have gone a little bit pear-shaped, really, because our canoeist has gone downstream, let the crocodile, and he's kind of about to be chewed up. So I suppose the idea here was, okay, the horse is bolted, as I said earlier, something has gone wrong, which is not what we want. Ideally, we want to prevent and preempt all errors and certainly all harm, but that unfortunately doesn't always happen. Now, in this particular instance, it was a very serious, potentially very serious incident. Luckily, no harm occurred, but very serious harm, fatalities actually have occurred in other jurisdictions. And the error was related to local anesthetic systemic toxicity, or LAST as the abbreviation is. So go to the next slide, please. Thank you. So what this was about was where a levopivocaine wound infusion was connected IV instead of to the neuroaxial catheter. So it was an incorrect connection, and there was no harm, but there was potential for this to be catastrophic because the local anaesthetic could have been infused. Well, it was infused IV for a period of time before the error was detected. We were extremely lucky. There was no actual harm resulted, but it was a really useful incident from a learning point of view. There were multiple contributory factors, as there always are with these serious incidents. And when we looked into it, all sorts of things, I suppose, came to light, which were very, very helpful in terms of us improving our systems and processes. So, there were issues relating to staffing. As there again often is in these cases, there was understaffing on the particular area that evening due to sick leave. There was inexperienced staff through no fault of their own. They were being drafted in to help in an area that they were not familiar with. And obviously it's a very specialist type of treatment for patients. Staff, should have specialist training because of, and that this was in the midst of COVID and all of the stresses that prevailed in the hospital. That training had not happened, even though it had been requested. The timing it hadn't actually it'd been planned, but it hadn't happened for the staff. So they hadn't had the training that normally would be, I suppose, required to actually administer neuroaxial preparations. So wound infusions, paravertebral infusions, or epidurals. We require our nursing staff to have gone through a specialist training program. But that hadn't been possible. So there was all those staffing issues. There was also, whilst there was a protocol available specifically for wound infusions, it had been written, but it wasn't available on our hospital intranet. And again, this was quite interesting when you looked into it. We have had a real explosion of the use of paravertebral and wound infusions in the hospital. So what had been once, we would just have had epidural infusions. Now we have all these other specialist infusions as well, not just on specialist areas either. They've gone out to general wards, and it's a whole explosion of a very specialist type of treatment. And this really highlighted that change as well. If you go to the next slide there, please. Thank you. So I think this incident was very interesting as well, because it really highlighted that your incidental findings can be the most critical. And the incidental finding in this case that was just found out by chance, serendipitously, really, when we started looking into this, was that we had levopivocaine stored on the ward in 2 locations. So first of all, it shouldn't have been on the ward at all, in the sense that one of our control measures was that it should be held only in recovery. But because there's been such a huge increase in the use of these infusions on this particular ward area, they had started storing it locally with the best of intentions, but that wasn't known by all parties. I suppose wasn't officially kind of agreed in the hospital. And whilst they had a segregated cupboard for this infusion, which would be according to best practice, and keeping it away from all other types of infusions. Unfortunately, not all staff knew about that, and some of the bags were actually in an IV medicine cupboard. So you had, they were mixed with IV infusions. Now, that wasn't the source of this error. Just to clarify that, in this instance, actually, the staff member had left the ward and they'd gone to recovery to actually pick up the infusion. So this was really not linked to the error, but it was a very, very important finding. When we were made aware of that, then we could sort it all out, get all the storage, agreed by the pain team, and we felt it was important that this was stored locally in this particular area, because it was safer than the staff going to and fro for maybe up to 4 patients a day to try and get these infusions off the ward area in recovery. I think the other important kind of principle this highlights is the gap between work as imagined and work as done. So what we perceived maybe was happening on the ward was very different to what was actually happening. And people are very creative in trying to, I suppose, make things work in very, very difficult circumstances. So I thought that was just another really good example of what was going on here. So next slide, please. Oh yeah, and so this is our medication minute. We did a lot of work, I suppose, behind the scenes in terms of getting protocols signed off, in terms of getting the storage, etc., agreed and made official. And then we had our medication safety minute, I suppose, to highlight this particular issue. In this instance, I should say there was no harm to the patient. The patient was treated very effectively and very rapidly. But when we spoke to people, there was a real, if you go to the next slide there, please, there was a lack of, I suppose, awareness amongst staff generally about this, I suppose, potential risk, and certainly how to treat it, and the fact that the antidote interlipid is only stocked in theatre. And we also didn't even actually at the time have an order sentence for it on our electronic prescribing system, because it was just so unusual. So whilst again that did not result in any harm in this particular instance, it was really valuable learning. We could then build an order sentence for it, make sure that it was available for prescribing should it come to pass that it would be needed. In this case, it was retrieved from theatre, ready to go. In the end, they didn't actually use the interlipid, but it was retrieved just in case it was going to be needed. But the patient actually recovered and was fine. So if you go to the next slide, please. Thank you. So this is my last example. Again, we have a reactive scenario here. This is what I mentioned earlier about a casual conversation being so important. Something mentioned kind of off the cuff, and this was a conversation I was having with one of the endocrinology registrars, and we were talking about sodium glucose cotransporter 2 inhibitors, and the phenomenon of euglycemic DKA. So I knew this was a risk, but I was kind of thinking about it more theoretically. But he was saying, we've had about 5 of those in the last few weeks. We're having literally 1 of those every week. And to which point I thought, oh my God, this is crazy. And we've got to do something really quickly, and we've got to do something for the longer term. So if we go to the next slide, please. Thank you. So I suppose this was one of those scenarios where, I really reacted as fast as I could, because I just thought we cannot let another one of these happen if we can at all prevent it. So we did an immediate kind of warning blast out to literally everybody in every possible way. And it definitely did get through, because we wouldn't do this often. So I remember talking with a surgeon a couple of weeks later, and he said, "Oh my God, what's going on with this?" So it definitely penetrated the organization. It was quite powerful. We designated the SGLT2 inhibitors as high alert on the EPR, our electronic patient record. We designated them as high alert for our pharmacists, so they'll be prioritized for review. And this alert also pops up, as you can see here, for dapagliflozin, to hold or suspend these drugs in patients who are acutely unwell or during perioperative prolonged fasting periods. This was where it was all going wrong. People's SGLT2 inhibitors were not being held in the perioperative period. And as a result, then patients were developing a DKA. As it happened serendipitously at the time, we were actually developing clinical pharmacy, and I were in conjunction with the endocrinology team, were developing perioperative guidelines for type 1, type 2 diabetes. So this fitted in very nicely with that. So if we go to the next slide, please. This is an extract from the guidelines, so we built it into that, if you like, as well. The warning about needing to hold. So those guidelines are available now to our staff, and are widely used, because we didn't really have we had a protocol, but it was a very detailed, very text-rich protocol, I suppose, prior to this. This is whereas now we have something that's a little bit more accessible, I think, or a lot more accessible, hopefully. It's people are finding it useful to get that kind of very precise guidance. But thankfully, we haven't had one of these incidents reported since we did, I suppose, all of this work. That would have been probably mid last year, I think, mid 2021. And finally, if I think we go to the last slide, I believe it is. Oh no, sorry, I forgot my medication safety minute. People may have seen this, but it was basically to get across the idea that this is an adverse effect that flies under the radar with SGLTs. And what is it? And next slide, please. Thank you. And obviously, it's euglycemic diabetic ketoacidosis. And why is it under the radar? It's under the radar because people can have absolutely fine glucose levels that can be absolutely normal, and it's actually not recognized sometimes when the people are in DKA. So it's really interesting. So people can come into ED and they could be actually experiencing DKA, but it's not recognized because their glucose level is normal. So if the thing is their ketones are going to be off, but that needs to be measured. But if they're on SGLT2 inhibitor, it's a good question or a good thing to think about if somebody comes in and they're very, very unwell. nausea and vomiting, etc. So it's a very interesting one, and it's really increased. I think the number of papers or accounts of this in the literature now has really exploded from the earlier years, I think. So it seems to be increasingly recognised. Okay, and next slide, please. Thank you. So this is my final slide. I think I'm probably run over slightly in time. Again, people may have seen this slide already, so apologies for those who are seeing it for the second time. But it's really just to sum up, I suppose, some of the learning points that I have come to, I suppose, come to my awareness over years of doing this job, some of which I've mentioned in the course of this presentation, not necessarily all linked to the Medication Safety Minute, but some are. But I just thought it was a nice way of polishing off the presentation. So I think the key points are the need for positive relationships with colleagues can't be emphasized enough, because people don't trust you, they don't like you, they won't talk to you, you don't know what's going on. It's that simple, really. And then I suppose also the need to build medication safety intelligence or safety intelligence by looking at lots of different sources of information, not relying on a reporting system. Don't underestimate the power of a chat or a coffee or a meeting in a corridor. Very, very important. And then I think to be open to the idea that you might start investigating one thing, but it can go off in a different direction entirely. And a single issue can lead to a much, much bigger thing. It could be a comment somebody makes when you're investigating one thing, and if you start kind of poking into it, can become something quite different. That's all, I think, totally normal and to be expected. It's just the nature of the beast, as it were. I think one thing that really always sticks in my mind is the need to be aware of severity bias and judging an incident by its outcome. I think this is a terrible problem, because you can have, the exact same incident happen and two different staff members involved, and depending on the look of it, one can have a terrible outcome with the patient, and the other case, the patient can be absolutely fine, and the staff member may be, there's a risk they will be judged as a result of what happens with that patient, even though the error is the exact same in both circumstances. This is something that really troubles me a lot, and it's something we should, I suppose, be really aware of, I think, in the arena of safety. There, but for the grace of God, go I, as it were. I think just a couple of other points I'd make is just look for connections between medication safety issues. If you can link them, like with the hypoglycemia, hyperkalemia, that was really powerful, because both audits supported each other, and we ended up with much more, I suppose, credibility with what we produced as a result, because we were bringing the renal team and the endocrinology team kind of together to drive towards a solution. It was a nice, it ended up being a good piece of work. It goes without saying, but the importance of honouring the past and building an organisational memory, because you find the same instance will come back to bite you if you don't deal with them. So remembering what has gone before and building on it. And then I suppose point number 9 really is kind of a little bit about the medication minute, embedding learning in formats that are easily and reliably accessible. And then obviously finally keeping the patient as your guiding light, and you will not go far from the right road. I think that always holds true. That's my 10th and final point there. So thank you everyone very much for your attention, and I think I might have gone over time, so if anybody has any questions, I can answer them very quickly. Thank you very much.
So yeah, if you have any questions, please type them into the chat box. Thanks, Eileen. That was fantastic. Louisa's going to get her slides up and ready to go, but please don't let that distract us from any questions that might be coming in. Eileen, that was one thing actually that came into my mind during that was about the investigations that take place in terms of maybe managing errors or identifying problems. And how is that information gathered in your setting? Is it through a log, an electronic log? And then how are the investigations? Or is it through like a root cause analysis, or can you talk me through the kind of process there?
Yeah, sure. So the reporting it's an electronic reporting system. It's based on our intranet. It uses a commercially available program called Audits. I'm not sure a lot of people have heard of it. It means that the report can be generated by any staff member from any computer in the hospital. It goes automatically through to myself and to the manager of that area. So there's total transparency, kind of visibility of the incident. The actual investigation then, it will be based on root cause analysis principles. Yeah, absolutely. So identifying contributory factors and then figuring out what of those can we actually do something about. It's all based on a focus on systems rather than than on individuals, and what are the underlying systems problems, rather than seeing it as human failures. I always say, like, I've no interest in who made the error, really, in so long as they recognize the learning, if you like, and it's all about what can we do to fix our system, because it's always about the system at the end of the day, So yeah, in a nutshell, that's kind of it. I hope that answers your question.
Yeah, I think the levobupivacaine example, the examples that you kind of the causes you mapped out, was like, it just kind of struck me as kind of a fishbone analysis being done on the thing.
Yes,
yes.
But
there are many other models, aren't there? But
absolutely, like all of those types of very, very simple, very useful models, like white 5 whys or fishbone, or I suppose mapping where people are at a certain point in time, like kind of time maps, that sort of thing. Use all of those. They're so kind of common sense in a way. You're using them almost without realizing them after a certain while. And there's also a Yorkshire framework. People might have heard of that. That we is kind of our official document in the hospital, which basically is a list of contributory factors under various headings, like be it staffing issues, or environmental or patient factors, that type of thing. But it's all it's pretty intuitive. When you've been doing it for a long time, you kind of you can sort of slot them into the categories kind of fairly quickly. But I think it's about looking broadly and asking questions, so you're not you don't get too fixated kind of with the minutiae, but kind of looking at the broader picture. And
and I'm thinking that's something that could be replicated in a community pharmacy setting. These kind of models that exist, they're widely available, and they help with mapping and tracking down where issues have happened, as opposed to focusing on who are the outcome. As you say, it's often more systems based issues are contributory, aren't they?
It can be so distressing to see the people focus on the outcome, because, as I say, that particular incident, I think, really illustrates that levobupivacaine one could have been horrific. Thankfully, it wasn't. But as I say, that's purely maybe the look of it and the robustness of the patient in that particular instance. So whereby if something bad had happened to that patient, I dread to think, of the staff member involved, and you'd be trying to protect people from that. But it's kind of, I suppose, the way the world works. But it's the learning we can get from it. And your no harm incident or your near miss could be the most, and that was probably the most serious incident we had that year. Most definitely it was. But there was no harm to the patient.
We have 1 or 2 questions come in, so we'll try and take these, and then we'll move on to Louisa. So Louisa's plenty of time. So there's a question about how findings are shared with other hospitals. Is there a central toolbox available? The questions come in from Justin.
Okay. So with other hospitals, I suppose probably the way that comes to mind would be the Irish Medication Safety Network, and the documents produced by the network. And we also have, through the network, we were all sharing anonymously and general issues from our hospitals in that way, so there's representation across the country. That would be a hospital-based network, so but there is a website, and there's lots of information on that and documents that, so it's the imsn.ie.
Thank you. Another question come in from Niall here, wondering about the use of tracer type audits for identifying issues or knowledge gaps. Have you found these useful in comparison to the use of more traditional types of audit formats?
I wonder what tracer, what is meant there now. I'm not entirely sure what that means.
We can await more clarification, see if it's come through here. We can wait. If Niall wants to maybe type clarification, we can take it at the end after Louisa's, if
sure,
that's okay.
Sure, of course.
See, should all patients undergoing colonoscopy be told to withhold SLGT 3 days before procedure? It's a query, I suppose, about some of the particulars of the information you've delivered there.
Yeah, and absolutely. So we say 3 days before and day of, I believe it is. It's on that slide, that one of the slides I showed there. So that's what, that's what we.
And those slides will be shared afterwards, so you can have a look at that information when that's there. Thank you so much, Eileen. We'll see if Niall comes back with clarification.
Absolutely,
but if not, don't worry.
I'll be here.
We'll keep you on the line. Thank you very much.
Thank you so much, Mary.
But without further ado, I'll just turn to Louisa now. Thank you, Louisa, for bearing so patiently with us. And Louisa's going to talk about some of the local initiatives that she has overseen and been involved with, and some of the medication safety issues that she's aware of within her role. So I'll hand over to you, and I'll put myself on mute. Thanks, Louisa.
Thanks a million, Mary Claire, and I suppose thank you very much, Eileen, for a really informative presentation. And Eileen is always a really hard act to follow. So I hope that some of the information here is going to be useful and informative and a good update. So we're going to talk about 3 topics. I want really to talk about medication safety at transitions of care, and I suppose the impact of COVID-19 on that. Some evolving information around trauma prophylaxis in pregnancy in COVID-19, and some few little nuggets of information around COVID-19 vaccination safety, and just some work, I suppose, that I've been involved in here in the Midwest about proactively trying to promote medication safety in my role as a HSE pharmacist, and collaborating with my colleagues in hospital pharmacy around some medication safety topics. So transitions of care, and everyone always asks, what are transitions of care? And really it's when any patient moves either from the community into the hospital or another setting like a hospice or residential care facility or step-down facility or rehabilitation facility, or comes back into the community from one of those particular facilities. And this has been recognised for a very long time as being a high risk for medication-related incidents. And this, I suppose, is piggybacking particularly on work that's been done here in Ireland by Tamazine Grimes, and then also internationally. And even back in 2014, HICWA would have issued guidance to be used both in hospitals and also in residential care settings around medication reconciliation, recognising that medication reconciliation at the time of transfer is an important control to reduce this risk. And medication reconciliation is something we do as community pharmacists day in and day out when somebody comes with a discharge prescription from the hospital. And sometimes we don't recognise that what we're actually doing is medication reconciliation. And Ireland is different, I suppose, from other jurisdictions. When I worked in the UK, all discharge prescriptions were dispensed by the community pharmacy. So before the person even left the hospital, all of their medicines were replenished and topped up by the hospital pharmacy. And I remember being a patient, it's interesting often to be at the other side, and I, as a patient, getting a bag of antibiotics and analgesics and walking out of the hospital without a discharge prescription. It was just so alien to me, because in Ireland I'm so used to getting discharge prescriptions. And what had been reported, I suppose, both to UL Hospital Group and also through the community healthcare organisation where I'm based, is that we were seeing an increase in errors on discharge prescriptions. And it's very hard to know whether this was due to COVID-19 and maybe some of our more vulnerable patients maybe not interacting in the same way that they would have maybe interacted with care services before, in that they may not have been able to present maybe to GP or community pharmacy, or maybe it was just that there was an increase in reporting activity around medication errors. But I know myself, having worked as a community pharmacist, I often would have encountered errors on discharge prescriptions. So it was decided by UL Hospital Group to develop a medication safety minute, because that is something they do, I suppose, taking example from Eileen's great work. And the idea was to send out that medication safety minute to all the community pharmacists via health mail within the Midwest, with a very kind of clear message around not assuming that the prescription is correct, and giving some examples of some of the incidents, I suppose, that had occurred in UL Hospital Group. One was in relation to anti-epileptic medication that had been omitted from a prescription, and another one was where 2 antiplatelet agents, clopidogrel and ticagrelor or Berleek, having been on the same prescription. What should have happened there was the clopidogrel should have been stopped and the ticagrelor should have been commenced, but unfortunately on the discharge prescription both items were there. So very much the message was, do not assume that the prescription is correct. And I know, community pharmacists, we look at the prescription and we think, the patient is under the care of a consultant, the consultant knows what they're doing. But a lot of the times the prescriptions that are being written maybe by junior doctors who are hungry, angry, later, tired, which, and particularly during COVID-19, we've all been very, very stressed, and they're very stressed and they're under time pressure. So that has increased as well, I suppose, some of the incidents around medication safety. And also the message to contact the hospital with any queries. I suppose, having worked in the hospital setting myself, I'd be very familiar and very comfortable with ringing up the hospital and speaking to somebody on switch. But, you know, if you've always worked in community pharmacy, you may not be aware around the fact that the hospital telephone number is present on the prescription, and the details of the ward, the clinic and the prescriber's bleep should be present. And what was a really good example as well of dual feedback was the community pharmacist came back with feedback saying, you know, sometimes the prescriber's bleep isn't present or it's not legible. And I fed that back to UL Hospital Group, and there was some education done there around, you know, the legibility, you know, and making sure that the prescribers would have put their bleep on it. But again, you know, the staff on switch in all hospitals are really, really helpful. And, you know, often the addressograph will have the name of the consultant, and the switchboard will have a list of the prescribers and doctors that are on that particular team. So they're really, really able to help. So again, the take-home message is don't assume the prescription is correct, and don't be afraid to contact the hospital if you have any queries or concerns, because we are, you know, as community pharmacists, often the gatekeepers on discharge to make sure that our patients are kept safe. Another example, I suppose, around proactive medication safety was University Hospital Kerry came to me and asked, you know, we're highlighting that they were getting a lot of telephone calls from community pharmacists querying around prescriptions that they were seeing because around thromboprophylaxis and low molecular weight heparin in pregnancy. And I had also been receiving some phone calls in my office around pharmacists, you know, inquiring around, you know, this increase in thromboprophylaxis in pregnancy. So University Hospital Kerry came up with a communication that I would have sent out to the community pharmacists, you know, to try and address some of their concerns and to also signpost them in the right direction as to where to get further information to make sure that doses are correct, and also to explain the rationale as to why there would have been an increase in some of this prescribing. But thromboprophylaxis in pregnancy is actually a really good example of how things are changing and things are evolving all of the time. And prior to January 2022, the recommendation was that all pregnant women who would have become COVID positive were to receive low molecular weight heparin as standard. And this is because the risk of thromboembolic disease is increased during pregnancy and postpartum. And this appears to be further increased in the presence of COVID-19 disease, even though the absolute risk is low. And thromboembolic disease with SARS-CoV-2 infection in pregnancy may be more likely in the presence of more severe infection and hospitalization. And this then was the reason why in January 2022 there was a change, because with the increase in the Omicron variant, we were seeing less severe infection and less hospitalization. And the evidence base in the clinical setting is evolving and may be incomplete due to the exclusion of pregnant women from many clinical trials. So what happened then was there was this guidance that was issued that was a collaboration between the Irish Haematology Society Coagulation Special Interest Group, the RCPI's Institute of Obstetrics and Gynecologists, and the HSE's National Women and Infants Health Programme. And the change was that COVID-19 was now considered as an additional transient risk factor for thrombosis and was to be incorporated into VT risk assessment tools. So every hospital has, maternity hospital has VT risk assessment tools. So instead of COVID-19 being an absolute for thromboprophylaxis, it was now going to be in with the transient risk factors. And other transient risk factors would be immobility. So for example, if a pregnant lady might break her leg during pregnancy or sprain her ankle, she'd be immobile for a period of time. So that would be another transient risk factor. Or, you know, if the pregnant lady has to have surgery during her pregnancy, that would be a transient risk factor. It only lasts for a short period of time. More kind of fixed risk factors would be things like a lady having a BMI greater than 30 at her booking appointment, or a parity greater than 3. So this would be her fourth pregnancy, or at an age greater than 35. So the duration of thromboprophylaxis, if it's prescribed, and most of the VT risk assessment tools would say that in order for thromboprophylaxis to be prescribed, that you need to have 3 or more risk factors. It should be individualized, and in general, it should be continued for as long as the risk factor for thrombosis is present, which for COVID-19 would range from 7 to 14 days in acute short-lived illness to longer periods. in women who may have more severe illness and ongoing risk factors for thrombosis, and post-discharge thromboprophylaxis or postpartum thromboprophylaxis for up to 6 weeks may be required if women have ongoing risk factors, including immobility. So again, the dose of low molecular weight heparin in pregnancy is weight adjusted, and this is generally based on the patient's weight at the booking assessment. So it's not maybe their current weight if they're, further into their pregnancy, but this is usually at 12 weeks gestation. And enoxaparin, tinzaparin, or dalteparin are the agents that are usually prescribed, and this is a very useful link. This guidance, the RCOG guidance has got a really useful table where they have the enoxaparin, the dalteparin, and the tinzaparin, and the different weight bands and the dose then that is recommended. So the next thing that I wanted to talk about, and the last thing that I'm going to talk about, is around COVID-19 vaccination safety. And I suppose COVID-19 vaccination in community pharmacy was a great example of exemplary and excellent pharmaceutical care provided by community pharmacies being able to scale up in a very, very quick manner to providing COVID-19 vaccination. And I suppose I wanted to talk about 3 particular points around COVID-19 vaccination, because we are continuing to vaccinate in community pharmacy, and it may become more complex as time goes on. So one of the key pieces that I wanted to speak about was about adverse drug reaction reporting. And we all know that the COVID-19 vaccines have been centrally approved by the EMA, but then the HPRA here in Ireland will report any nationally occurring adverse reactions to the EMA. And adverse reaction reporting on the ground by us as community pharmacists and other clinicians who are vaccinating is a really important part of the intensive monitoring plan for these COVID-19 vaccines, so that any change in the benefit-risk balance can be promptly detected and acted upon, so that, for example, if a vaccine is showing, a large amount of adverse reactions, that the appropriate action is taken, whether that be, certain restrictions in relation to age, of the cohort to be vaccinated, or changes maybe to the patient information leaflet, and this then will enable the EMA to continue to safeguard public safety. And the COVID-19 vaccines are subject to additional monitoring, so they've got that inverted triangle, and that you'll see on the HPRA website or the EMA website if you look for the SPC. And this allows for quick identification of any new safety information. So it's really important that if, as a pharmacist, you encounter any suspected adverse reactions, that they're reported to the HPRA online is preferable. There is also the yellow card, but the online system is very easy to use, very user-friendly, and it also gives you a reference number where you'll be able to track the report. And it's really important to include as much information as in the report, and particularly the vaccine batch number should be included. So some questions that I get in my role as a HSE pharmacist is how to manage medication incidents that might occur during the vaccination season. So it's very important to locally report and record any incidents during a vaccination season session, because we need to take a positive approach to any incidents that occur, and it's important to have a no blame culture and not to be punitive, but to look at the whole process as a whole and to identify any learning in order to improve the quality of the service that is being provided from the vaccinations. So in the case of any medication errors that would directly involve the vaccine recipient, so this is where maybe the wrong vaccine is given, the wrong dose or the wrong route, and the incident must also be recorded in the local incident records, and a full investigation should be undertaken to identify the root cause of the incident, and any learnings should be identified and implemented. Open disclosure is so important, so the vaccine recipient and/or their significant others should always be informed of the incident. And the National Immunisation Office, the NIO, will be able to advise on any required follow-up contact using this particular email. And it's best to communicate with the NIO via health mail, because this is, our secure email, and also not to use any patient identifiers in the communication. And again, if any suspected adverse reactions associated with medication errors are encountered, they should be reported to the HPRA as per the previous slide. So I suppose one evolving factor is, around multiple vaccines. And if there are a number of vaccines in use in a community pharmacy, whether these be different brands of COVID-19 vaccine, or maybe COVID-19 vaccine and flu vaccine, or COVID-19 vaccine, flu vaccine, and maybe other vaccination services that are being administered in your pharmacy, it's very important to put risk mitigation factors in place to prevent any incidents. And the 6 rights of vaccination administration really bring us back to the very start, to ensure that the right patient receives the right vaccine at the right dose via the right route at the right time, and the right records are made. So some, I suppose, suggestions maybe to improve safety is to schedule vaccine specific days or sessions where possible. So, maybe to have if you've got Pfizer vaccine and maybe Moderna vaccine, to do Pfizer vaccine one day, Moderna vaccine on another day. Maybe have, particularly with the Moderna vaccine, having a different dose for the booster versus the primary course, doing primary course vaccination with Moderna on one day and the booster on another. Training is really, really important. And it's not just for the vaccinators, it's for all staffs that are involved, because you may have non-pharmacist staff who are involved in checking patients in. You may have non-pharmacist staff who are observing patients after the vaccination if observation is required. So training is required for all staff who are involved in any steps of the process, even if they're not a vaccinator. It's really important to confirm the vaccine type with the recipient at check-in, at consent, and immediately prior to administration, and also to check before each vaccination. If at all possible, a single independent check on the vaccine to be administered should be carried out. And also you can ask the vaccine recipient to read the syringe label and vial aloud to confirm that that's the correct vaccine and the vaccine that they are expecting to administer. Confirming the date of birth and age at all steps in the process is also very important. I don't know, as I get older, I'm looking at people and going, how could you be born in 2005 and be 16? And I think maybe if it is that, pharmacy is called to vaccinate the younger children, this will be particularly important, because there is a different formulation for the children aged under 12. And separate storage is always, a really good way of managing vaccines. And I know it may not be possible to have, different fridges, because that's what they would have had in the vaccination centres. They would have had different fridges for the different brands of vaccine, or when they were vaccinating for flu and COVID-19, they would have had different fridges, and even fridges on different floors of the centre. But, having dedicated maybe label storage in the fridge, or using different shelves, may also help. And it's really important to keep as up to date as possible with the HSE's operational guidance. This is always changing and constantly changing. So to make sure that you're regularly checking this particular link to make sure that you've got the most up-to-date operational guidance. And this particular link is actually really good. It's from the NHS, and it gives really, really good guidance around handling multiple COVID-19 vaccines in a number of settings. So the take-home messages are: do not assume that the hospital prescription is always correct, and if in doubt, make contact with the hospital. Data is always evolving, so check the up-to-date resources if in doubt. Report all adverse drug reactions related to COVID-19 vaccines to the HPRA, and think of the 6 rights of any vaccination, so that the right patient receives the right vaccine at the right dose via the right route at the right time, and that the right records are made. So thank you very much, everybody.
Thank you, Louisa. That was really interesting. So we have, hopefully colleagues are having a look at the chat box. There is some information being shared there, and then some examples of good practice that are happening, particularly in relation to, say, for example, managing the COVID-19 vaccinations in practice are also being shared. So they're very useful. Thank you. Just to acknowledge that Niamh was thanking the role of community pharmacists in helping with medicines reconciliation, and acknowledging that is part and parcel of everyday practice, and can be time consuming, but is so essential, obviously, for patient safety. So thank you for acknowledging that, and I'm sure the community pharmacists will be thrilled to hear that, because it is something that happens every day, isn't it? There's another signposting here to a useful document. So IMSN 2020 conference shared feedback, medication safety issues initiatives from Irish Hospital from survey in 2020. And then the active participants in global recommendations on safe COVID-19 vaccination practices. And there's a PDF link provided there. And so literally published in January 2022. So if you're interested, do have a look in there. Louisa, I think, you know, the bit I enjoyed about your presentation, it gave us a rapid fire, you know, overview of really key and up-to-date issues. So about thromboprophylaxis and signposting, where we can get more information about dosing. You know, I think that's going to be really useful for many of the pharmacists who are joined us this evening. I note that you were talking about the COVID-19 vaccinations and obviously reporting issues, but I suppose just about maybe near misses and gathering information on that, or maybe how they're managed in practice. Do you have any experience of that in your role?
Yeah, so I suppose, Mary Claire, it comes up a lot in that community pharmacists are asking how to manage near misses. So we don't, and I suppose this is a huge gap, is that there isn't a cohesive way in which for all incidents that we can report incidents together. So my advice to anyone who has encountered near misses is it's really important to report any near misses, you know, in the same way that you would report any medication incident, and to investigate them in the same way that you'd investigate incidents, and put measures in place, because again, it's about proactive learning. And even if it is something as simple as taking out the Pfizer vial instead of the Moderna vial, well, why did you do that? And, you know, was it to do with storage? Was it that, you know, that somebody was being distracted? And making sure that you put good measures in place. But what I'd love to see, Mary Claire, and it's probably something for the future, is that we would have a repository where, you know, as community pharmacists, we'd be able to share our incidents, because I do think it's really, really important, you know, that we can learn from each other, because I often find as community pharmacists, particularly working in independence, it's very, very hard, you know, maybe to learn from your colleagues, and it's something I would have seen in hospital as being really, really useful, but we don't have that here. But that's definitely something I'd love to move on.
Okay, and in terms of where those near misses should be reported, where's the best place to report those?
So yeah, so they'd be reporting those locally. So I suppose for some of the chains, they'd collate their near misses together, but you know, it would be, if it's an independent pharmacy, to report them locally, and for the supervising pharmacist and superintendent pharmacist to look at those, you know, in a manner that's local to them.
Yeah. Okay. Thank you for that. I'm just looking here at our chat to see if anything else has come in. So there are great observations by colleagues, and you can take the time to read those in the chat there. And primarily thanking our two speakers this evening for their presentations. My intention with this was to give a good overview about primary care, secondary care, pertinent issues, ways of managing and thinking about medication safety issues, and hopefully we've had loads of examples of different things from practice this evening that everyone will have gotten something out of it this evening. We'll share the feedback survey in the chat in a moment, and I'll also just signpost you to our future session, our next few sessions as well. So we'll just pull up the slides for those.
So just pop the
thank you, Audrey. Yes,
survey in there, and I'll
surveys.
this.
Thank you. So we really welcome your feedback, both on this evening's session, but anything you feel like we should be covering, that you feel is relevant to your practice and maybe it's not been addressed yet in your learning. We very much welcome that feedback. The next session on the 9th of March is looking about fertility and pharmaceutical care considerations of management of fertility. So this is something that has been called for many times in the feedback that we've received. And we've been looking for a speaker, and so fortunately we have Jonathan Marcy, who's a very experienced community pharmacist, and will speak to us on that issue on the 9th of March. We have another speaker on the 23rd of March, and I want to flag it to you now because I think it will be a very popular webinar also. Niamh Fitzpatrick will join us, who's a clinical psychologist, and she will talk to us about having compassionate conversations in pharmacy. So engaging with people who are grieving or perhaps who are recently bereaved, and how we conduct those conversations and engage with those patients or carers and family members within our practice. And I'm really looking forward to that presentation, and that will be on the 23rd of March, all going well. So we very much welcome any commentary you have, within the feedback survey. If you want to tweet, the Twitter handle for the Institute of Pharmacy is up there. And we advertise obviously all the webinars both through Twitter, LinkedIn, and also on our Instagram as well. So thank you for joining us this evening. I'm going to pause the recording now. And if you want to stay on and ask any further questions, you're very welcome to do so.